this week on the Backtable podcast.
So when people think that something is easy because manually it's easy to do, this could be a problem. That's why we need to be severe, because we have the experience and the authority as a neuroradiologist to say, okay, this is a apparently easy treatment, but like everything that is easy, you have to be extremely careful, sometimes even more than difficult things. When you are doing some difficult, your alert is a very high level. When you do basivertebral ablation, you try to do, okay, it's an easy thing, it's an easy treatment, it's an innovation, who cares? Okay, better to be prudent. Otherwise, we risk to burn and to destroy a procedure that works.
Hello, everyone. Welcome to a special ESNR edition of the Backtable podcast. This is your host, Jacob Fleming, and I'm here with a good colleague and mentor, Dr. Luigi Manfre. He's the Secretary General of the ESNR and the director of the Hands-On Spine Course, returning to Italy this October 16th and 18th. Dr. Manfre, welcome back to the show.
Yeah, thanks, my friend Jacob. I'm very happy to be back here on Backtable, because I know that it's like an extremely powerful system and a very, very successful podcast. So it's really an honor to me to be there back again.
It's great to have you back, and you were one of my first guests back. It's been a few years now, talking about spinal stenosis and interspinous spacers. And we're going to talk about a few things today, including the return of the hands-on course this fall. And then we'll talk about the European approach, or the Sicilian approach to basivertebral nerve ablation, and
Exactly.
pick your brain on that. So I had the opportunity to attend the course last year, which hard to believe it's been now a year. Fantastic experience getting to see you and spend time with international colleagues from dozens and dozens of countries, and spend some time at the Mediterranean Institute of Oncology, where we got to do all kinds of phantom-based techniques and just see everything that was coming out. It was just a fantastic experience. And so this year, it'll be continued this time in the fall, October 16th and 18th. Why don't you tell us about what's in store for this installment of the course?
I remember when we started this kind of course, it was a sort of my creation, a sort of a baby for me. We decided to do something completely different, not a congress, not a course, no lectures, zero lectures, because people, find courses everywhere and every time, and there probably is even too much, according to me. But the hands-on is another story, because the fact is that no matter how many courses you attend, the best part of our life and our job is move your hands. If you're interventional, you want to move your hands and you want to try. And I remember when I was young, and unfortunately many, many years ago, but when I started to do and I did my cadaver lab, trying to understand something and to learn something, well, it was completely fixed on my mind. The thing that I used, well, it becomes, part of my life immediately. So probably the success of the hands-on is related to the fact that we don't talk, but we act immediately for 3 days. And up to me, and according to what I know, it's the more complete hands-on in the world, because it's 3 to 4 days, 100% spine, working from 8 a.m. to, I would say, 7 p.m., but sometimes it's even 8. But people are happy. People don't get tired. They are happy to work continuously. And we show, from the basic to the advanced procedure, starting from the ultrasound guided procedure, because ultrasound is important in our hospital, and then we move to the fluoroscopy and then to the CT. We will show this year MR guided procedure that will be the future for us, and we will talk about what is on the market and something about what will be in the market in the incoming future, because I want to love to show not the past and not the present, but the incoming future. That is what you will use in 1 or 2 years, according to me.
Yeah, I agree. That's one of my favorite parts about the course and these international, as you said, it's not a congress, but the coming together of minds. We get to see what different techniques and devices we're using. And it's very interesting. I was speaking to Dr. Kalekis about this recently, that I always had this impression that Italy or Europe in general always gets the cool stuff first, and the new techniques and devices. But interestingly, basivertebral nerve ablation, which we're going to talk about, is one of these ones that actually seems to be more easily available in the U.S. To my knowledge, that's one of the few places where we've been ahead. But this is something that's completely changed, I think, the approach to chronic back pain in general, and attendings will get to see this as well as many of the other techniques that are. If not on the horizon, then already arrived in some cases. So it was very energizing to get to actually use the things that I had only seen before with Q Fusion, Lobster, and things like this. And what I really learned a lot from was your approach to doing CT guided procedures and using a combination with fluoroscopy. So that's something that I think the attendees will really enjoy. And that's something also that I want to talk about with you when we talk about technical factors of BVNA. So the course will be excellent, October 16th through 18th this year, and back at your home institution, correct?
Yeah, back in my institution, because we as a European society, try to, number one, create a course that could move a lot, in Europe, and we will repeat the experience of a Middle East course. We did 3 Middle East course in Qatar. It's a sort of a twin course, but less day. Just 1 or 2 days. And we will repeat it in 2026, probably in Dubai or in Qatar back again. But for the European course, the main problem is honestly that we work, as you know, we are in 4 to 5 simultaneous room using simultaneously CT, X-ray, C-arm, whatever we have. But the fact is that if you want to organize something like this for 3 continuous days in a public hospital, is difficult because you have to stop people, and you cannot say, well, sorry for you patient, but you have to go back home because, okay, let's come with your disease in 3 days because now we are closed. You cannot do this. In my institute, thanks God, probably they love me a lot, but I don't know. We managed to stop the activity, not only my activity, but the activity of the buildings for 3 days and more, because we have to prepare the room. So honestly, a sort of a 1 week. But for that week, no patient, zero, distraction, no other problems or issues. We have everything for us. And this is a great advantage. That's why we repeat in Sicily back again. At the end of the story, Sicily got excellent weather and excellent food. So people will not complain. If they come back again, they don't complain, honestly.
No. We had a great time visiting in Catania, and it was a very nice combination of just the Italian hospitality and less of a big city vibe as Rome or other places. So it was a fantastic experience. And I can't believe a year has already gone by since then.
Me too.
Yeah. So let's jump into talking about basivertebral nerve ablation. And you and I have discussed this before, but I really like getting your perspective on it because you have a few different approaches using CT and also kind of, like I said, a European approach to it, maybe a little bit different than what we use in the US. And so why don't we just jump in talking about what is the clinical problem or the clinical condition that basivertebral nerve ablation addresses?
Yeah, well, basivertebral ablation is an excellent choice, and I remember we were the first in Europe to start to do the BVNA in 2017, and it was a problem because it was completely off-label. We used the materials that we use generally for tumor ablation. It's just radio frequency. But it worked well, and we were very, very enthusiastic about this kind of treatment. It's an easy treatment, honestly. It's an easy treatment, particularly when you use your CT machine, according to me. But when we started, we got a lot of problems related to legal problems related to the fact that it was, an off-label treatment. Nowadays, is worldwide recognized. So thanks God, we have the permission to do this treatment that is extremely powerful for the back pain. But I remember when we started, there were a lot of perplexity, and particularly not so much enthusiasm from orthopedic side. I would say from orthopedic side, because they keep on saying, no, this will not work. What's the sense of burning nerve inside the vertebra? What kind of nerve are you talking about? I mean, this nerve was discovered very late. Was described in 2011 in most of the papers. So it was something new. Nowadays is powerful. And my question is, when I talk about this treatment, is why it doesn't work in older people. But another one, I think that we should analyze how to do this treatment. And I think that the most critical things in our activity is patient selection. I don't know if Jacob if it's your experience, but Jacob, the selection of patient is quite difficult.
I think it is, and it's an area where, as radiologists, we can have an advantage being used to looking at spine MRI, and many of these patients tend to be on the more elderly side, and so have a slew of other issues, and so sorting out both imaging-wise and clinically the pain generators, it can be difficult. And I found absolutely it's true that patient selection is the key to success with the treatment. And so the kind of things that we're looking for, namely, would be Modic 1 and 2 type in-plate changes. And these are extremely common. And so I've heard a bit of a misconception from some radiologists that, that tiny little Modic change, you see that on everybody. That's not, well, you see it on a lot of MRIs of the lumbar spine that are performed for back pain. and especially Modic 1 changes have a pretty high likelihood ratio of being symptomatic. So these things, which can be subtle, should not be discounted, I think. And of course, discogenic and vertebrogenic pain exist on a spectrum. And so these patients have a bit more advanced degenerative disc disease with in-plate changes. And to me, it makes sense that they have probably had discogenic pain for some period of time. And so once we start to see these Modic changes on MRI, there can be a very high chance that they are symptomatic. And another thing that we know, there's been a misnomer for a while that Modic 1 changes will eventually become Modic 2, and those are kind of quiescent. But actually, there's been more data showing that these can reconvert back. So Modic 2 to Modic Definitely. 1. And so it's a dynamic process. But the basivertebral nerve innervates the end plates. And it's a really interesting treatment in that compared to the other peripheral nerve ablations we do. The intraosseous basivertebral nerve doesn't appear to regenerate after ablation.
Zero. I mean, it's completely another story. Well, that's why that was my perplexity. And as you know, I spoke about these issues just at the last American Spine Society meeting. We were in San Diego. The fact is that, to me, if it's only, if you analyze all the literature, okay, there is a very recent paper about the analysis of all the papers that came out about the basivertebral ablation treatment. And it's a very precise analysis. And the mean success rate is 74. That from one point of view, it's excellent. 74%, it's a very high percentage of success. But my question was, if it's such a stupid treatment, burning a nerve, it's easy. Okay, so if we have only to burn one single nerve, so there is no risk to fail your procedure if you do technically correct your procedure, why don't we have 100%? Because when my dentist come and open one of my teeth because I got tooth pain, you remove the nerve and the pain is out 100%. So why doesn't work 100% in the vertebra? That's why I focus my attention on a lot of things that I want to analyze with you. And I will not talk about clinical symptoms. Unfortunately, clinical symptoms is, okay, can suggest you the presence of vertebrogenic pain when you got pain, inflection, bending over, but it's not 100%. There are no, demographic issue that can be combined, no predictive things that 100% works. The most critical thing is that we should understand why we fail and how to select these people. You talk about Modic 1 and Modic 2, and you're right. It's so easy. Every one of us got Modic 1 and Modic 2. And so I try to go deep inside these first things, that is Modic. Then I will talk about innervation of a vertebra. That is another story. It is quite interesting because there are many papers that changed our idea about the innervation of a vertebral body. But let's speak about Modic 1 and Modic 2. I got a question. I always say, I got a question. Why Modic 2 should be painful, according to you? I mean, Modic 2, it's stupid fat in the bone. It's not painful. Fat is not painful. There are no nerves inside. I mean, what's the sense of a Modic 2 that is painful? Modic 1 is the only one that is related to the pain. And there is a precise association between the volume, the area of Modic 1 and the VAS scale. So this is the only 100% association in the literature. The amount of Modic and the amount of pain that people have. So I analyzed Modic 2. And you know that always something that I always say, I'm a neuroradiologist that trusts on nuclear medicine. Because you know that all my patients, from the very first one, started to do MRI and then a bone scanning with the SPECT CT. SPECT CT doesn't look to edema. SPECT CT shows you the chronic turnover. That is the results of a chronic inflammation. So it's more than Modic. It's something that talks to you about biochemistry, about the biological changes in a vertebra. When you have a true Modic 2, you do a bone scanning, a SPECT scan, and the SPECT scan is negative. There is no bone turnover increased. But this is the true Modic 2. The most of Modic 2 we see and we report in our papers when we look to the imaging are not true Modic 2. It's a mixed combination. You do your bone scanning, you do SPECT scan, and there is an uptake, but the uptake is related to the inflammation that is part of Modic 1. We cannot think that in one day, 100% of Modic 1 turn to Modic 2. No sense. Probably, exactly as you said, it's a sort of a flowing combination. So there are cells that go to 2 and cells that go back to 1. So the most of Modic 2 are hybrid Modic 1 and 2. That's why when we treat these people, we have a results, because they have pain related to the part of Modic 1 inside the Modic 2. So according to me, number one, I don't trust. I know that in the United States, there is a sort of a flow chart, and there is the paper that says, okay, you have to select people according to Modic 1 and or 2. For me, Modic 2 is 0, no selection at all. If I see, and if I have a patient with a true Modic type 2, that means bone scanning 0, SPECT CT completely negative, I don't go for basivertebral ablation. I'll tell you more. I got patient with Modic 3. Nobody talk about Modic 3.
Nobody.
Okay.
Nobody does.
Nobody. Who cares? It's a sort of a racism against Modic 3. Who cares about Modic 3? Everything is bone. Who cares? Well, we do bone scanning, and there is the uptake. Simply because there is an inflammation at that area. So, when we talk about Modic 2, we have to understand that what we see on MRI is different from that is a picture about increasing water, is different from what we see on SPECT scan, that is a picture of metabolic changes, that is the inflammation. That's why, for example, I delete completely Modic 2 and I focus my attention on Modic 1. And now we have another problem. Modic 1 sometimes is very, very faint on MRI. And you see that many people got Modic 1, but it's just a ridiculous amount of abnormal changes. Then we do the SPECT scan, and there is an inflammation that is a drama, a tragedy. So there is a mismatch between a very poor amount of Modic 1 on MRI and an incredible inflammation you see on bone scanning. The fact is that Modic 1 that you see on MRI, it's edema. And this edema is related to the fact that the disc is squeezed between the two vertebrae, and there are a lot of inflammatory things, together with water, obviously, that are squeezed inside the bone. Obviously, if you analyze your patient lying down in supine position, it's completely different than analyzing people in the upright. When you look to the Modic 1 in the upright, you will see that there is an increasing inflammation in these people. I got an upright weight-bearing system in my institute, and I know that when I analyze people in supine, I see 10% of Modic 1. Then I move in the upright, the patient, and the Modic 1 area increase up to 68%. 68% more. Remember that the volume of Modic 1 is the only thing that is related to the pain, directly proportional. Okay, so the fact that we see a very low level of Modic 1 on our conventional MRI, probably it's a false. That's why when we do the SPECT scan, we see an incredible inflammation in comparison to the small amount of Modic 1 we see on conventional MRI. Because we should compare SPECT scan with the upright MRI. If we do an upright MRI, I trust on what I see. Modic 1 is the real volume. If I don't have the upright MRI, I do want a SPECT scan, because I will see the exact amount, the real amount of inflammation of a vertebra. So we move to this concept of selecting people after doing a SPECT scan. And there is another story, and there is another issue that is fundamental. You see a Modic type 1 in one picture. Okay, tell me when it was born. Because you can have an acute Modic type 1. And you have a chronic Modic type 1. Exactly as you said, Modic type 1 can disappear. If you do, in the acute phase, if you do correct physiotherapy, sometimes we see disappearing of Modic type 1. So it's reversible. For me, it's fundamental to understand when a lesion is a chronic lesion, so we need to burn a nerve, we need to do a treatment, or it's an acute lesion that is better to call a physiotherapist and not me. That's why we do the bone scanning, because PET scan discriminate between the acute lesion and chronic lesion. If I don't see in the late phase, you know how PET scan works. You do a double step. Okay, you have the first inflow scan that is for tumors and for acute inflammation, and then you wait 3 hours and you have the late inflow scan. The late inflow scan is for chronic disease. So if I don't see anything on the chronic phase, this is not a chronic disease. It's acute. You are not supposed to go inside the vertebral body, burn a nerve for an acute lesion. No sense. So that's why I'm so fond about SPECT scan, because number one, I see the real inflammation, no matter if it's Modic 1, 2, or 3, but I see the bone turnover. Number two, I see the real amount, not only the inflammation, but the real amount of inflammation, because I looked at the biochemistry or the vertebra, so the bone turnover, that is the direct expression of a chronic inflammation. And number three, I can discriminate acute inflammation from chronic inflammation. Acute inflammation, go for physiotherapy. Chronic inflammation, welcome to basivertebral nerve ablation. That's why I discriminate all my patients with these, with this disease. And honestly, I want to add something else. Bone scanning for me is important, even from a legal point of view. Because I will never forget one of my patients with, for me, it was a Modic one, definitely. I would bet my degree it was a Modic one. And then I have bone scanning, and there was an uptake. That is bone turnover. But the fact is that there was a bone turnover even in the first inflow phase. So the phase that is for acute inflammation or tumors. That patient got a lymphoma. And we did the ablation because the ablation was invented for tumors, not for the basivertebral nerve. So the treatment is equal, the treatment is the same. We did the biopsy, but this was a tumor. It was not an inflammation. So bone scanning is one step that explain you why we have 74% of success when we trust only on MRI. We don't have 100%. And this is the first side of the moon. Then we have another side of the moon that is even more complicated, that is innervation. Because innervation in a vertebra is not exactly how we think. I mean, there is a very, very interesting paper came out last year. They did a lot of sampling in a Modic 1. And in the Modic 1, they saw some changes. From this sampling, they discovered, number one, that there was an increase in bone marrow stromal cells numbers. Bone marrow stromal cells are the cells that promote the neurite overgrowth. So inflammation, more bone marrow stromal cells, more nerves, hyper innervation at that level. And simultaneously, the chronic inflammation in Modic 1 activate a lot of enzymes, elastase. There are a lot of enzymes that destroy the stroma, the extracellular space. So we have simultaneously an increasing bone marrow stromal cells. That means an increasing number of nerves, and simultaneously a destruction of the extracellular space. So we create holes that are ready to be invaded by this nerve. And this hyperinnervation is something that we can try to control with our treatment, but we don't control, everything. We burn a nerve. We don't change the chemistry, the biochemistry of a vertebra. It is not a treatment that solves the problem. It's a treatment against the pain. We remove the nerve, but Modic will remain. Inflammation will remain. We don't change the biological aspect of the vertebra. And there is a third factor, just to complicate all the things together. They discovered that basivertebral nerve is not the only nerve in the vertebral body. And I was really surprised because I was told there is the caput medusae, all the nerve go through the vertebral body and then converge in a single nerve. Let's burn the nerve and that's it. Unfortunately, this is not true. Things are more complicated because they discovered that in the end plates, particularly in the end plates, that is the trigger point, definitely. In the anterior and in the posterior part, there are a lot of, not in all people, but in many people, there are a lot of small nerves that skip the basivertebral nerve and go directly in the sinovertebral nerve. So there is an extra circuit that is completely skipping the basivertebral nerve. So if we treat a patient that got two circuits, one, the conventional basivertebral nerve, and the other nerves that come from the hand plates and they go directly in the sinovertebral nerve, so they skip the basivertebral nerve. No matter how much we burn the basivertebral nerve, they will have a second circuit that will still feel the pain. That's why probably we don't have nowadays 100% results. Number one, for the patient selection, Modic 1, Modic 2, Modic 3, which is the real Modic volume, which is the real Modic to be treated. So bone turnover, SPECT scan. And the other face of the moon is the variability in the innervation of the vertebral body. Because it's not only one nerve, like for my tooth, but it's for my molar, more than one nerve. And if my dentist forget to remove all the nerves, still will have the tooth pain. And the same for the vertebra. We can burn the basivertebral nerve, but we definitely cannot burn the thousands of small nerves that from the hand plates go directly in the sinovertebral nerves. It's not for all. They say that this variation of innervation is not in everyone, but there are people that got this kind of strange innervation. This could explain why we sometimes have failure, even if we do perfectly our job. We go exactly in the mid of the vertebra, according to Intercept study. We go in the midline and in between the anterior 2/3 and the posterior 1/3, and we burn and 60 degree or to 90 degree. No matter how precise you can be, if there is a second nerve that skip the basivertebral nerve, done. Unfortunately, you cannot resolve the pain problem in this patient.
It's very interesting. Everything that you just said really makes me think about everything differently with a different element. And I think what it gets to, especially with the example you used about doing weight-bearing imaging and seeing the increase of Modic 1 changes. So we have a problem of sensitivity and specificity for using what we see on conventional MRI. And so the edema that we see from Modic 1 changes is kind of a surrogate for inflammation, but like you said, it's in the acute phase, it doesn't necessarily correspond with chronic inflammation. And that can often resolve, like, I feel like I see these sort of acute looking schmoral nodes where it seems that they've just had a herniation, and that seems to resolve on its own a lot of time, whereas these more chronic confluent Modic 1 changes are probably more associated with SPECT scanning. I haven't got into using the SPECT scanning yet, but it's something that my local neurosurgeons have for other reasons. So I think that would be really interesting to look at with a more research focus prospectively. But and then the redundant innervation is so interesting, and I think this gets back to vascular nature of interventional radiology, and nerves and vasculature have a lot in common in terms of redundancy, kind of anastomoses, if you will. And we know that there's a lot of anatomic variability between patient and patient. So it makes sense to me that there's also variation in the innervation. One thing that I think is really important, as you were talking about the failures, and this may be due to additional pathways of innervation to the end plate. A really good example is that patients can have a compression fracture after basivertebral nerve ablation. And I think it's important to mention that we have at least one study showing that probably the incidence of a compression fracture in patients with osteoporosis especially is probably at least 20%. So this is something, the burning of the nerve, as we know with bone tumor ablation, we'll never do a tumor ablation without kyphoplasty. And of course, the difference being the basivertebral ablation has a much smaller zone, but we've still seen it to possibly predispose to an additional fracture. And so I would tell to these patients the same thing I tell to my patients who I'm treating with kyphoplasty for the first time. You are at risk of having a fracture. It's nothing to worry about. Let me know if you start to hurt. We'll rescan and see if there's a fracture and treat it promptly. But important to note, that patient will hurt from a compression fracture, even if their basivertebral nerve has been burnt. And this is something that our friend Doug has impressed on me. And the anatomic and histologic explanation that you just gave of these redundant innervation pathways explains why maybe we are having failures when just based on we're not catching what we need to see on MRI. And it really makes me think in general, for though, we always want to learn from our failures and get to a point where we have treatment options for those patients who maybe are not going to respond 100% to basivertebral nerve ablation. It makes me think about, down the line, how may we approach pain coming from branches of the sinovertebral nerve? Any thoughts on that?
Yeah, but it's the same story we have, for example, in the SIJ, sacroiliac joint. And sometimes it happened to me that I have a patient that with a SIJ disease demonstrated by MRI, bone scanning, 2 block tests, intra-articular block tests. So they have the disease. No way. Then we put the screws. Doesn't work. And then we do the ablation. Doesn't work. And then they discovered 2 years ago neurovascular bundles that go over the SIJ. So there is a sort of a bridge that is over in the soft tissue, starting from the sacrum, getting to the iliac bone, but it's not, along the conventional pathways that all we know, from the lateral margin of the S1, S2 foramen, blah, blah. There are bundles in the soft tissue that fly over the SIJ and from the sacrum land on the iliac bone. So no matter what we can do in the SIJ, the patient still has pain. We burn the nerves in the SIJ, but there are an extra circuit. We put screws, but there is an extra circuit. That's why there is sometimes failure. But on the other hand, guys, okay, we have failure. Everyone got failure. There are no procedure that 100% work in the surgery. But on the other hand, we have 74% of success in a back pain that otherwise was treated in the past with ridiculous things like screws and rods or posterior fixation or extremely aggressive kind of treatment, or drugs, chronic drugs, that it's a problem because chronic drugs create another damage. So the fact is that even if there are failure, do the basivertebral ablation because it works in 3 patients on 4. 3 patients on 4 justify a treatment. The only thing is be extremely severe in the selection of patient. Try to use whatever you have. I'm waiting for people that will study with the MR spectroscopy the edema of the vertebra. Probably they will have new information to give us and saying, okay, the vertebra with an increasing amount of lactic acid, there is more probability of success. Let's try to use whatever we have to get better our definition of a patient affected by vertebrogenic pain. But in the meanwhile, we need to treat this. So do the BVNA, do the basivertebral ablation, even if you have success in 3 on 4. 3 on 4 is is sufficient to justify a surgical minimal invasive treatment, according to me.
I agree completely. And of those 3 out of 4, these patients get an average of about the same, about 75% pain reduction, which is astounding. The same figures for interbody fusion surgery for the same condition, stable axial back pain, is much lower, around 30%. And of course, with this treatment, there's no bridges burnt. Whereas as soon as a patient is fused, the clock starts to tick on adjacent segment degeneration. And actually, one place where I've seen this technique to be really good is for patients who have adjacent segment degeneration with Modic changes adjacent to a previous fusion. And so this is something that's really good for them. And oftentimes those patients are like, I do not want to have another surgery, which is understandable.
Because simply they will create the same condition in another place.
Exactly.
No sense.
Yeah,
no
agreed.
Sense.
So let's talk about the technical approach to this. And so in the U.S., this is primarily done under C-arm guidance. And so much similar approach as kyphoplasty. One thing I will say is I've done a lot of kyphoplasties, and I've done a pretty good amount of basivertebral nerve ablations. And I find that the easy basivertebral nerve cases are about the same difficulty as a hard kyphoplasty. I'm not sure if anyone would agree with me on that, but the targeting can be difficult, and you can do it perfectly, and sometimes the curved curette just it won't go where you want it to. and this has been one of the difficulties that we've had, and particularly at L5 and S1, the approaches are technically a bit more difficult because of the cranial angulation that you need. And S1 in particular is very difficult because the pedicles are just very different from other levels. And I have a very low threshold to use a technique that Dr. Beal taught me, which is the transiliac approach, much like placing a screw or doing a lateral approach biopsy. Of course, it's slightly more invasive, goes through some more soft tissue. But these are all factors and potentially complicating issues that will come up during the procedure that have to be planned for. And so I tell any of my colleagues who are getting into BVNA, absolutely do it. be prepared that the cases are definitely more involved. I would say. But I'm curious, what is your approach? Are you using exclusively CT or the combination of CT and C-arm?
Well, I use always the CT and that's it. Because I find CT, easier to use and to get exactly the center, not the center, but the midline, and then between the anterior 2/3 and the posterior 1/3, that according to me is the best place to put your needle. I always use a unilateral approach, and I use steerable needles. So I don't need to burn all the whole vertebral body. I just burn a spot. But the most important thing is get the spot. Get the center where the basivertebral nerve starts. So number one, I use the CT for this reason. Number two, I use the CT because exactly as you said, L5 is another story. L5 is a different vertebra from the rest. It's not concave posteriorly, but it's convex posteriorly. So sometimes on the C arm, there is the risk, according to variation, the morphology, there is the risk that you pass through the lateral recess, hitting and there are many papers describing hitting the S1 in the lateral recess during a procedure, because many people got this very extreme convex posterior wall in the S5, in the L5. So for L5, I do believe that the CT is the best, but I use the CT honestly for this treatment, only the CT. About S1, it's a problem because you cannot skip this problem changing the technique. You can use fluoroscopy, you can use CT, but whatever you use, getting the midline and getting the center of S1 is difficult and is not for all. It depends on the morphology of the hip, morphology of that area. So sometimes I analyze all my patient I did. I think that I got the higher casuistic in Europe, okay, about the BVNA, because we published in 2020. So honestly, many hundreds of. But the fact is that I analyze people with 5 and 1 inflammation, L5 and S1. That is quite common. And I noticed that despite the fact that I treated these people only at the level of L5, so I didn't touch the S1 because it was not possible to put the needle in S1. The results were fine. So I treated only one of the two levels, and the pain significantly was reduced, despite I treated only one level. Honestly, Jacob, I don't have scientifically proved explanation for this. The only thing that came into my mind is that you have an inflammation of L5 and you have an inflammation of S1, identical. But L5 moves a lot because it's L5. So if you have an inflamed L5 that continuously moves, okay, you stimulate the pain. S1 is inflamed, okay, but S1 is part of the sacrum. It doesn't move. It simply sustains the compression of the body. But we cannot say that S1 moves like L5. It's only a part of the sacrum. So probably, but we are talking about friend. Nothing is proved. But my idea is that sometimes we have the same rate of success burning L5 and not S1, simply because L5 is a moving vertebra. So when inflamed, stimulate the pain more than a single part of the whole sacrum. So we treat L5 and we obtain the same results in our patient. That's why I don't get desperate if I have a patient where I can do the treatment on L5 and I cannot do anything on S1. And definitely, I will not go through the iliac bone. I know that I can get the center. I can go even through the belly if I want. And I get the center. It's easy. But the fact is that we have to understand where we need to stop. Okay, we can go everywhere with our needle. Me, you know, we can go everywhere. But I mean, the most difficult things in life is not doing something, but understanding when it's better not to do something
Sure, sure.
and stop a little bit.
Yes, and I think again one of the things I really like about this treatment is it doesn't burn bridges, and so doing that in a way where it still retains its very good minimally invasive safety profile is important. Like you said, it would be we could place a needle from anterior, but that would be very highly risky. Very interesting your anecdotal experience about the S1, and it makes a lot of sense to me. I think that's something that's worthwhile for us to look into as we go forward because S1, like I said, I would say that L2 through L4 are fairly easy. L5 a little more difficult, and then S1 tends to be the one that causes a lot of consternation during the case. And even on the C arm where we can oblique whichever direction that we want. So one limitation that you may run into, I imagine, with CT is the maximum tilt you can get on the gantry. How are you able to work around that? How does your system perform,
Well,
and how do you
honestly,
work around?
sometimes I don't care. But for example, I work in a place. I mean, I work in three places, but there is one of these three that's got the super extra CT, but it doesn't tilt. It's a 128, slices, but it doesn't tilt. But with the experience, honestly, our brain, we are a neuroradiologist. So even if we see something on actual, our brain create the 3D imaging. So I know exactly how to move my needle to get the center of a vertebra, even if I don't tilt perfectly according to the axis of the vertebral body. So this is, I don't think that is a great issue to me, honestly. We get the center with a steerable needle always. Well, in the future, we will do a lot of other things. For example, there is a new system that is coming on the market. It's a bilateral approach, not steerable stride needle, but you invert polarity between the two needles, so you create a sort of a crisscross heating area. So it's a very every area is not a very hot area, but when you do the crisscross, exactly where there is a superimposition of the two heating area, there is the burning area, a sort of a stereotactic radiotherapy. So two area not so hot, but when they cross in the mid, they will burn in the mid. This is another way too. I do prefer a steerable needle because I get the center and that's it. We one approach, but I mean you can use bilateral approach in the same things. I found always difficult when I have to treat people with the inflammation and Modic 3 because sometimes I do Modic 3 people, but here these people, the sclerosis of the bone can be a nightmare. I will never forget a patient, one of my first patient with Modic 3. I put my needle and then I did my job. Everything went well, no problem. Then when I stopped it to do my procedure, I tried to pull out the needle and it was fixed in the bone. So I started to pull with all my strength. And then the handle remained in my hand and the needle remained stuck in the vertebra of the man. So I have to take a great pizza and removing the cannula. But for that time, I wouldn't advise to treat people with extremely sclerotic bone because sclerotic bone is better than iron. I mean, when the bone is sclerotic, you probably you can manage to enter, but sometimes it's difficult to exit, and it could be an issue. It would be, an issue. It's the time when have to start to pray. That's
Yeah,
always work. I mean,
yeah.
always work in
It's
our job.
Yes, absolutely, and I agree. I had one of the harder cases in fellowship for BVNA. I remember was a patient who was probably in his mid 40s, and he'd had a prior laminectomy, and so at the level of the laminectomy, he'd started to develop what looked like some instability, and so he had exuberant implate changes because he was younger and not one of our usual spine fracture patients or older non-operative candidates. His bone not soft in any way. And just getting access in those cases can be really difficult. And sometimes, the primary system we use is one with a curved but not steerable curette, and that hard bone can really deflect it and make it quite difficult.
Absolutely. Absolutely. But it make it impossible, honestly. Really impossible.
It's a very nice treatment, and again, one of my favorite things is that it is very minimally invasive. We're doing it with poke holes, no incisions, and not burning any bridges. If it's done technically correct, you don't burn any bridge. You burn nerves, but no bridges. And so surgery is always an option, but in general, there's very little indication for these patients to go on to surgery.
No, definitely the neurosurgeon will refuse them because this is more not a mechanical, it's a mechanical problem, obviously, but it's even a biochemical problem. So make more sense a denervation than a fixation. More, something that acts on the receptors, on the pain structure, than not fixing the vertebra or injecting the PMMA like we did in the past, because I treated in the past many people with the Schmor's node, inflamed Schmor's node, injected the PMMA, and it worked perfectly. The pain disappeared simply because we thought that it was better to make stronger the bone, but it was completely untrue, which was false. Simply we burned the nerve using the PMMA. It was a chemical denervation, not a physical denervation, with the radioablation, with heating the nerve, but we simply destroyed the nerve with the polymethyl methacrylate. But it is the same story. Simply it was a denervation in any case.
Very interesting. And I'm excited to think about how we'll expand this treatment in the next few years. This is still very new treatment. As you said, the pathology of this was really only discovered about a decade ago. So it's cool that we're witnessing this turn into a validated form of therapy, which it definitely is now. And for me, this is something that's totally indispensable. I saw 3 patients in consultation on Friday, and 2 of them are, may potentially have basivertebral nerve ablation in their future. And these are all patients who are sent to me by neurosurgeons who don't want to operate. They don't see an indication for fusion surgery, which I agree with. So this is an area where we're expanding the treatment option for patients. We're not poaching patients, and I think we can work really well with our surgical colleagues, and they need help with these patients. We want to help, and it's a simpatico situation.
This is an area that will expand definitely. When they will create some device smaller, sufficient to treat the mid and upper thoracic level, for example, because how many people you see with a kyphotic degeneration, and then all the Modic changes, all the inflammation in the mid area, and they complain about this pain between the shoulders, exactly in the mid, and this is a typical inflammation. It's not Modic because Michael Modic classified this only lumbar area, okay, but it's the same things. In the mid-thoracic, now I cannot go in the mid-thoracic with my system. We need smaller needle, and even cervical is quite the same. It's more rare, definitely, but exists. The only problem I think that is just back in the kitchen when we talk about the basivertebral ablation systems is that at the end of the story, it's not a heart transplantation. It's not so difficult. And when things are easy to do, many people think that they can do these things. This is not true, because the easiest things sometimes are the most difficult to do. The most difficult thing is selecting properly the patient. Here, neuroradiologists, far in the future in comparison to other specializations, simply because we started, and simply because imaging in this patient counts a lot, more than clinical symptoms. So we have to be extremely severe, telling even to our colleagues to be severe in selecting the patient. Otherwise, my fear is many people will try to do this. A lot of people will do this. It's easy, but when you don't have a learning curve, correct learning curve, like for everything, then we will have an increased number of failure, and an increased number of complications. And in Italy, we got the same things with the ozone. Ozone is fantastic. Ozone works perfectly. Now, in the United States, you became very fond of ozone, and there are a lot of countries that use ozone. But then I remember in the past when ozone was invented in Italy, because it was invented in Italy. I mean, there's not the ozone, but the ozone therapy. I remember that it was easy, and that means that everyone started to do ozone, and then they did ozone for destroying the fat in the how you say the love handles, okay. And there was a lady in Naples that died because her hairdresser did the ozone for cosmetic thing, and they put the needle and they injected 10 cc of ozone in an artery, and the lady got an embolism. So when people think that something is easy because manually it's easy to do, this could be a problem. That's why we need to be severe, because we have the experience and the authority as a neuroradiologist to say, okay, this is a apparently easy treatment, but like everything that is easy, you have to be extremely careful, sometimes even more than difficult things. When you are doing some difficult screw fixation of C1, your alert is a very high level. When you do basivertebral ablation, you try to think, okay, it's an easy thing, it's an easy treatment, it's a innervation, who cares? Okay, better to be prudent. Otherwise, we risk to burn and to destroy a procedure that works.
Mm-hmm.
That's it.
Agreed completely. So well said. And it reminds me kind of what's happened with the medial branch ablations that, at least in our country, for Medicare specifically, this has been really clamped down on. That it's there's a lot of hoops that have to be jumped through just to get a simple facet procedure done. And part of this is because it's been overused for everything back pain. And almost every patient I have that I've treated with basivertebral nerve ablation has said, "Oh yeah, I had the ablation before." I said, "No, you did not have this. You had medial branch ablation." And because kind of the first response has become back pain, rhizotomy. And so I echo your concerns that we should make sure that this is used for the right indications, and even refining it further. Then right now we have a pretty broad definition of Modic 1 or Modic 2 in-plate changes. And one thing for me that I would really like to look forward to is, you get these patients who are elderly and they have Modic in-plate changes, Furman grade 8 discs at every level, and it becomes difficult to tell where is the pain coming from. And so doing more physiologic type of imaging with the SPECT CT, even with the weight-bearing MRI and the MRI spectroscopy, I hope that we'll see that the approach to this evolves, because I would much rather just ablate 2 levels rather than 5. That the procedure becomes very involved at that point, and this is we personally have our patients under general anesthesia for this simply because of the duration of the procedure. And so if we can figure out how to make this more of our surgical, SWAT team approach that we try to do in interventional radiology, and expand that to the other specialists who are using this, so that we can keep it safe and effective and reduce that failure rate, like you said.
And sometimes I'll tell you more. We do the MRI, and then we do the bone scanning, and then I do a block test. Because bone scanning, and sometimes you do the spexity, and exactly as you said, you see 25 and inflammation in 25 vertebra. Block test, even if it's not, officially recognized, it's not like the block test for the facet, but it's similar. But I'm used to do a lot of block tests for this reason. I go exactly where there is the inflammation according to the bone scanning. Then I inject the lidocaine, and if the pain disappears, for me, it's another, how do you say, brick on the wall. I mean, it's another information that is useful. Because sometimes injecting the lidocaine in the disc, for example, the lidocaine in the space, when you have the typical Modic 1, works perfectly. You inject the lido, the pain disappears immediately. I'm more happy to treat people with a positive blood test, because I have another Another things that tell me that I am on the right way. I mean, that patient got a real vertebrogenic pain. So blood test is something easy to do for us, and I think that is useful.
I think it's very useful. I do that on all potential patients. In fact, my first step for a patient who I think may be perfect candidate for BVNA, I'll always do the disc block or anesthetic discogram, as we sometimes call it, for them. And that's the first therapeutic step for me as well, because often I inject dexamethasone as well, as I was taught to. And I've seen patients will routinely get 4 to 6 months, even close to a year of relief with us sometimes. And if I can treat the patient with a block with a 22 gauge needle and not have to do something that's still minimally invasive, but more invasive with an 8 gauge cannula going into the vertebrae, I'm more than happy to do that. So this is something that I would advise other physicians to adopt. It's an easy thing to do and really helps out with the specificity as well. Well, Dr. Manfre, as always, this has been a fantastic conversation. I've learned so much. I can feel my brain expanding into understanding of vertebrogenic pain and seeing the paths we're going to in the future. So thanks so much for your time. And for our listeners who are interested in the ESNR course, where can they find out more information about this?
Oh, it's easy. Let's go to on the ESNR website, so esnr.org. That is the official website of European Society of Neuroradiology, and you will get all the information about scrolling and all the courses we organize. There will be the hands-on, and then get it, and then you will see everything. Or you can mail me if you want. You can mail me, and that's it. The only problem with the hands-on is that just to maximize the efficacy of the hands-on, we accept generally, no more than 30, 35 people. Otherwise, it's like the hands-on I saw, I cannot say which one, but we were more than 150. Okay, good for the organizer, bad for the attendees, because when you are one among 150 people, you can even not ask a question to the tutors. That's why I do prefer to be 30, 35, subdivided in 5 groups with 2-3 tutors for each group, the way you act. Otherwise, you are, one small dots among all the others.
Yes. Yeah. I thought the ratio was very good at the course. I think it's good to keep it that. And, for our listeners, again, if you're interested in attending, I would get on it quick because the spots will go. And we look forward to, in the next few weeks, having both Josh Hirsch and Alan Brook back on the show to discuss some of the other topics that will be germane to the course. But look forward to hearing about a fantastic and successful course later in the fall, and highly advise anyone who is interested to really consider it. I do agree with you that I think this is the premier hands-on interventional spine course in the world, and just can't say enough good things about it. So thanks again, Dr. Manfre, and thanks for your time.
Thanks for your time, guys. Have a nice night.
Thank
Bye-bye.
you. Bye-bye.
Bye-bye.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable MSK on Instagram, X, or LinkedIn. Backtable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.